Welcome.
And we're live.
And good afternoon and welcome to today's roundtable discussion on pharmacy benefit managers, what they are, how they work, why they exist, who runs them, and most importantly, what impact they have on the healthcare and healthcare costs of the average citizen. My name's Jack Finn with Red Rock Strategies, and we are here at the office of our great community partner, the Las Vegas Latin Chamber of Commerce. As always, a profound thank you to the people and staff at the Latin Chamber, particularly its president, Peter Guzman. You can access this roundtable presentation on the Latin Chamber of Commerce's Facebook page and their YouTube channel. Well, our current healthcare system is a virtual maze of data with confounding acronyms, burdensome requirements to get information, thousands of sources and resources, and many different players, from doctors to pharmacists to insurance companies to hospitals to government institutions at the local, state, and even federal level. For the average person, it can be confounding and aggravating. Add to the mix of acronyms and data are these three letters, PBM, Pharmacy Benefit Managers. Now, I'm guessing if you ask 1,000 Nevadans, what's a PBM? You get 1,000 Nevadans saying, I have no idea. But PBMs are a significant part of the system by which we access and pay for the medications that alleviate pain, reduce symptoms, and contribute to our overall well-being. They are very mysterious entities. Fortunately for us, there are very brilliant and well-informed advocates in our state who can help clear up for us what PBMs are and, frankly, why we should care. Three such advocates make up today's panel, and it is my pleasure to introduce each of them. Jeff Stone is a licensed pharmacist with more than 40 years' experience who has opened 6 pharmacies himself. He is a former assistant professor of pharmacy at the University of Southern California, an assistant professor of pharmacology at California State University, Dominguez Hills, where he taught pharmacology to graduate nursing students. Jeff, thanks very much for being with us.
Delighted to be here. Thank you.
Jim Lamb has had an extensive career in business, public relations, politics, and academia in his 50 years in Las Vegas. Jim has an MBA, and after finishing his second master's degree, began teaching graduate level marketing and undergraduate management. He has been active in local and state political circles, and much of his business work has involved government relations. For the past 15 years, Jim has been consulting with various startups. Currently, he is a board member of a biopharmaceutical company. He is vice president of Nevada Biotechnology and Health Science Consortium, helping to promote innovation in Southern Nevada. Jim, it's great to have you.
Thank you.
Thanks for being with us. And finally, Joe Greer. Joe is founding dean of the Roseman University of Health Sciences. He served as professor of medicine, founding chair of humanities, health, and society, and associate dean of community engagement at Florida International University, Herbert Wertheim College of Medicine in Miami. Joe has been named one of the 500 most influential business leaders in life sciences. He has written a book titled Waking Up in America. He's advised 2 U.S. presidents on healthcare policy, and he is the recipient of the Presidential Medal of Freedom. Other than that, he hasn't accomplished. Thanks for being with me.
Thank you for having me here. By the way, my mother said, even if I don't deserve it, don't return it.
Wise. The way this is going to work, I have a series of questions. I will start out the discussion by asking one of you to begin addressing it. But please, you're all here for your expertise. There are no points for shyness. Please feel free to jump in and engage. If you disagree with something, please feel free to disagree. We can have a lively back and forth. We have 2 pairs of boxing gloves if you really want to settle it man to man. But we're hoping for a lively and interactive discussion. So please weigh in at any time you feel is appropriate. And with that, let's just get started with a very general question. What exactly is a PBM, and how do they impact healthcare costs? Let's start off with Jeff Stone. Jeff.
Well, first of all, thank you for inviting me, and it's great to be with such distinguished colleagues here today. As you mentioned in my intro, I've owned and operated 6 pharmacies, and the first pharmacy I opened was in 1983, before we had computers. So we were filling prescriptions by something very foreign to maybe some of the millennials that are watching this, called a typewriter, and typing up labels. And if you had insurance, you had a little credit card. It used to be called a PCS card or a paid prescription card. You used to run it through like a credit card machine. And we used to fill out a billing for the insurance by hand for every company. So it was very tedious. And then in around 1986, the computers came out with pharmacy software, and we were able to communicate with insurance companies. Instead of filling out these paperwork bills, we could actually go online with a modem. We actually heard the telephone being dialed and finally connecting to the squelching sound, and hopefully getting paid for the claim. So it reduced a lot of paperwork. So pharmacy benefit managers initially were called switches. What they did was that they were the intermediary electronically between your pharmacy and the insurance company via this middleman called a switch. Fast forward to today, their role in adjudicating and paying and establishing eligibility for patients and what drugs are covered and which drugs aren't covered, which we'll get into more detail, they've assumed those roles. And formularies differ between insurance plans to insurance plans. But the problem that we have is that there are 3 large PBMs that cover almost 80% of the country's insurance needs for prescriptions. And these 3 companies have become multi-billion-dollar companies, and they really can throw their weight around. And I think through some of the discussions that we're going to have in your follow-up questions, we'll kind of identify what some of those issues are. I mean, they are important. They are important because the goal is to lower costs for our consumers. You know, we probably have the highest price of medicines in just about any industrialized country. But we also have some of the greatest pharmaceutical companies that come up with great cures, like Sovaldi for hepatitis C. And we need somebody to help manage the cost. But I think we better refine how that can be done.
As we manage those costs, are these benefits for the insurer, or are the benefits for the patient?
Well, it should be benefits. Obviously, it's the insurer that's contracting with the PBM to lower costs.
Right.
Hopefully, it's not just adding to their bottom line, but they're passing through a lot of these savings to the consumer, something which we don't see probably enough of.
And don't a lot of the insurers also have financial interest in these pharmacy
They
benefits
do.
managers?
And I think that is certainly a conflict of interest. There's not transparency because basically a lot of these PBMs are not regulated by the federal government. And some states have chosen to go ahead and start regulating them to make them more transparent, because what's happened is that they control billions of dollars worth of expenditures for medications, and the middleman, the PBMs, have decided, well, you know what? Well, why don't we take a little bit of the rake along with the insurance companies? But you're absolutely right. We have insurance companies, Caremark, CVS. We have one of the 3 Express Scripts that is publicly held, right? And then the third one is owned by United Healthcare.
Right.
So you kind of got the fox guarding the hen house a little bit. There should be some transparency that is not clearly seen, which could effectuate the prices the consumer sees.
Because I was reading where already 21 states have 32 legislative bills that have been passed for transparency. But this is only at the state level. And you had mentioned something.
There's a couple of in the federal level. There's one that's, I don't have the number in front of me, but it's, I saw a press release on it. It was from May of this year. And it's out of the U.S. Senate Committee for Commerce, Science, and Transportation.
Okay.
And hopefully it'll be coming up. It looks pretty good.
And bipartisan.
Mm-hmm.
Right. If they're so lucrative, why are there only 3?
Well, there's more PBMs than the 3, but
There's actually 66 in the country.
But why are the 3 able to monopolize the market to such an extent?
I think a lot of it could be the fact that those 3 represent some of the early people that were involved in PBMs. And one of the things about PBMs in the last, I would probably say 20 years, is there's been a lot of mergers and acquisitions and all this stuff tied to not only, I mean, the PBMs, but the people that started it, the insurance companies, or the entities that were back there in the 70s and the 80s and stuff like that with the early variation of PBMs. And they've kind of like the CVS one, it's kind of morphed because of the companies that were brought into the whole mix.
And wouldn't it be also that the insurance providers that have a financial interest are some of the biggest ones that exist? So they have the majority of the population.
You're talking United Healthcare.
United, you're talking Aetna with CVS. And
So what can be done to mitigate their impact, or what should be done?
I think you would be the best answer, but I think it has to be a word that nobody really likes, but you really have to have oversight and regulation. That's what you need to do. But and equal with that is transparency. Let us see what you're doing. From a physician's perspective, my frustration, and I'm a subspecialist, I'm a hepatologist, gastroenterologist. So the idea that I can prescribe a medication of which very few are available for a specific disease, but it's not in their formulary. So if the patient wants that medication, they got to pay out of pocket, which could be thousands of dollars. So you're taking away that decision-making from the physician. We understand it when I admit a patient in the hospital, the formulary might be different, but you got to be careful then too, because when the patient is discharged, you got to put them back on the medications that they were on. So it's something where I think pharmacists and doctors need to work very closely with.
I mean, it's a headache when you're a professional like doctor is, and nobody knows what's better for that patient than the physician. And what you have to do sometimes is there's only a specific medication that may work for this particular patient. And if it's not on their formulary, then the amount of paperwork and begging that you have to do by going to get prior authorization and dealing with people that aren't even physicians,
Right.
maybe physician assistants, with all due respects to physician assistants, but nobody knows better what your patient needs than you. And really, I mean, money's important. We want to curb costs where we can, but where we can't, and it's in the best interest of the patient, the insurance company should be compelled to pay for that medication that person needs. But a pharmacist should not have to spend hours on a phone. A doctor's office shouldn't have to spend hours on a phone to give a medicine that a patient deserves because they're paying insurance for that medication.
And also, as we see copays going up on medications on an annual basis, the inflation's not helping much at all. I mean, people now have to make real choices between my medication or do I eat or do I pay my rent? And that becomes an incredibly stressful thing to do to somebody. I mean, there was a report out by Pharma where the population that's most affected are those with mental illnesses. Mm-hmm. Now, we know for a fact that unless you can treat or mitigate the behavioral health disorder, you're never going to get to the physical disorder. Which is the irony I see, because if you're an insurer and you're paying for all this, that means you're going to have more hospitalizations.
Right, exactly.
So you can make the money in the short term. In the long term, you don't improve the health of the patient because, if you have a mental illness, which is, I think, the number one public health problem in this country right now. We're seeing that. You're seeing that with suicide attempts, suicides, substance abuse, and all that. We got to get ourselves back on track, but it has to be something that is achievable for a patient, any patient, whether you're a patient that has 2 PhDs or one that didn't finish high school, it should be made so that we get you back to resilience.
And how specifically do we do that when it comes to people suffering from mental illness?
First of all, we have a shortage of providers for mental illness. That's number one. Number two, we don't screen well enough in primary care. There, as a gastroenterologist, I would say 80% of my patients had an underlying behavioral disorder, whether it was anxiety, stress, depression, whatever it was, but it manifests itself in the GI tract. And why is that? Because the GI tract is only second to the brain in innervation. It's actually 3 separate organs that join together during embryologic development. So what ends up happening, that's where you get your acid, that's where you get your bloating, that's where you get your change in bowel habits, which can be debilitating to somebody. But unless you treat the underlying cause of it, I can give you all the medications in the world, but you need to treat the underlying cause. I mean, I'll give you an example. I had a patient came in her early 30s, a young, brilliant, type A Hispanic woman that gone to an Ivy League law school, and her next door neighbor had died of colon cancer, who was her best friend. So she was sure she had colon cancer. She came in, I need a colonoscopy. After a long discussion and looking at everything, she really had no indication for a colonoscopy. So I said, come back when you're 50. It's now 45, by the way. And so she came back 20 years later and said, do you remember me? I said, no. And she goes, well, I was a patient with you here 20 years ago. And I said, well, how'd you do? She goes, I did everything you said and I felt great. I said, really? I go, what did you do? She goes, I got a divorce. I said, I told you to get a divorce? She said, no, you told me to get rid of my stress.
So we're talking about stress and mental illness, and we've got the phenomenon of PBMs, which we've already noted have a distinct lack of transparency. How does that manifest itself in the community of those needing mental health treatment?
Well, the thing is what I'm hearing from the experts in health here, is there needs to be some sort of, I guess you could say, consistent access the patients have to all the types of medicines that are out there, not just, you were talking, I keep flashing about the 8-track. I'm sorry, I had an 8-track, okay? Okay, for those of you who don't remember, this is right after vinyl records. They had things like cassettes and 8-tracks. Okay.
And remember, you couldn't fast forward or rewind.
Right.
You had to play it all the way through to get to the start you
And
wanted.
of course, the thing is you had to have an 8-track to play an 8-track
Right.
tape. If you had the cassette, you had to have a cassette tape. Or with video, you either had a Sony or you had a VHS. There was no crossover. I mean, and even Apple computers and the Microsoft, but eventually you start looking at, now you can run Microsoft programs on Apple, you can run Apple stuff on Microsoft. There develops a commonality that I think that patients are going to look at, that it shouldn't matter what PBM or what insurance company that they have, that there is an access. Now, it could be a situation where there's a slight cost difference or something like that, but it shouldn't be, okay, you can either go this way and have this access to this medication or go someplace else and have access to this one. But if you don't have one or the other, you're not going to get it. And that should not be the result.
And the other problem is the electronic health records do not talk to each other. And they aren't going to a central place. In medicine, we count on our peers, our professional peers. I'm a subspecialist. I write you a prescription. The patient might not have brought in their entire list of medications they have while we're doing the reconciliation. So I'm limited to what I can see, what could be a potential interaction. When I send that prescription to the pharmacist, I'm counting on the pharmacist to sit there and also consult the patient and do all that. By the way, I want you to know that Roseman University, we have the only pharmacy school in all of the state of Nevada.
Nice.
So
And you've had that for quite a while.
we have.
I've heard it's very impressive.
So I just wanted to throw that out there. Just
I appreciate that, Doctor.
and our football team is undefeated.
So one thing that we can all
Yes,
agree
please.
on is that when new medications come out, the doctors usually see representatives of the pharmaceutical companies touting the advantages of these new medications that are therapeutically better, less side effects, and the last thing they usually share with the doctors is probably what the new medications cost. And
Right.
frankly, new medications are costlier because for every new drug that comes on the market, probably 40 of them that they've invested in to get on the market don't. So you can't deny them to make a profit to do research and development to find cures for things like hepatitis C, which I alluded to earlier. But in the area of psychiatry, you're dealing with some very specific drugs for some very specific disorders. And it's like a round peg going in a square hole sometimes where it's not covered. And a lot of times, I hate to say it, it's not covered because the HMO or the PBM hasn't negotiated an appropriate rebate or discount with a competing pharmacological class of drugs if one exists for that particular drug. So these are the dynamics that you come in contact with. As an example, I had a patient that was doing fantastic, had a history of depression, that was put on a very good antidepressant called Prestique. He was on Prestique for almost 10 years and never had one depressive illness. And then changed his jobs, got different insurance, went to get his prescription filled. They even had a generic for it. And they said, I'm sorry, but that's not on the formulary. We're going to have to put you on another drug. And the other drug was a drug that he'd failed on before and went back to the hospital with a depressive illness that cost the insurance company a heck of a lot more money. So the psychiatrist had to get on the phone for a long time. The pharmacist had to get on the phone because this patient was running out of their medication and was at risk of having a bad episode. And this is where you shouldn't have to spend hours begging the insurance company to pay for a medicine that the person has been stabilized on, is living a good quality of life. Yeah, it might be a little more expensive than a typical generic antidepressant, but it works.
Which is the other problem, is the lack of transportability of your insurance.
Yeah.
Because not only does that happen, but then all of a sudden you might have to change your provider. So the patient, we're taking away that choice from a patient. So, I mean, which is, there's, if you're within a system, you have the providers there and different things like that. So there's arguments for both on either way, but just changing a job and doing that. So we have to have some sort of transparency with that also, which means that the provider industry and the business world have to get together.
And you're describing interactions between doctor and patient, doctor and pharmacist, pharmacist and patient, patient and insurance company. Where are the PBMs? And they're such mysterious entities. You can't call up your PBM and say, why isn't my medication on this formulary? I mean, how does that work for the layman?
From a layman, they generally come back to the pharmacist or the physician and say, what do I do? Unfortunately, many people, when they get a prescription, don't know it's been switched, even if they're told, because they figure, well, that must be okay. My doctor signed it. And the pharmacist said, okay. Well, the medication might be under, this is a list of medications for depression. It's like we have a list of medications for antihypertension. But some people with certain heart diseases cannot take certain medications, so it's the complexity of the different things that occur with it. Somebody with severe liver disease or kidney disease really needs different dosages, depending on that, because that's how you excrete the drug. And the other thing is, they don't have that information, that clinical information, when they make their formularies. And so the formulary says, this is the equivalent doses, I'm going to give this to you, but it might metabolize differently.
Right.
So you have a lot of side effects that can occur with it.
Everybody's so different. I mean, as much as we are the same, we're different. I mean, I don't know, I have certain things that if you give them to me, I go bonkers, but, I'm sure somebody else has the same thing. But people have allergies. And sometimes you have allergies that don't even show up until you actually take something.
Right.
And you don't know it until it happens.
Well, a recurring theme is the level of transparency that PBMs enjoy. What can we do about that, and how did that come about?
Well, the transparency is because you've got various, somewhere I have a list here of all the different, as far as when you're talking about, they got rebates, things, they got various administrative fees, they got DIRs, they got all sorts of different, if you want to call them playgrounds, that they can vary they can get costs out of, they can get money out of. Some of them, there was one that, you're talking clawbacks. I don't know, that's kind of a weird one, but I looked at it and excuse me, isn't that a kickback? I mean, it just, it's so many avenues of revenue that they're into now. It's not just.
Let me tell you,
Are they in fact
And they are profiting very, very well.
Oh, yeah.
and let me tell you about an issue from a pharmacist perspective. You talked about clawbacks. When I had one of my retail pharmacies, I had a pediatric patient that had asthma. And so the doctor prescribed a albuterol inhaler. They prescribed 2 of them, one for home and one for school. So I filled 2, right? The insurance company allowed a 34-day supply. Okay, well, I can't take an inhaler and take a saw and cut it in half. I have to give them 2, or the kid's going to be at risk of having an asthma attack that might take him to hospital and he might die from it. So what these PBMs do is they come in and they audit your books. So the PBM inspector comes in and says, hey, you dispensed 2 of these. It's more than a 34-day supply. And I explained, well, he's got to have one at school. He goes, well, we're going to cut you back one because you exceeded the 34-day supply. And what they also put in the PBM contracts is that you cannot go back to the patient family and request them to pay for that extra inhaler. And you're not allowed to discuss the terms of the PBM contract with anybody. Otherwise, you're at forfeit of losing that PBM. When you consider 3 of them cover 80% of the people in the United States, if you're one pharmacy, an independent, for example, they pull your contract, guess what? You're out of business.
The contracts are between the PBMs and the pharmacies.
That's correct. And the contracts are obviously written very much in the favor of the PBMs, where you can not do a lot of things that you would like to do. In one case, it's actually written in PBM contracts that they may have on their formulary a brand name drug that is on the formulary. And you may have a generic drug that's the same thing that you could offer to them less expensively. In the contract, it says you can't do that.
Mhm.
If you do that, it's a violation of the contract, even though you're supposed to be working in the best interest of the patient to make sure not only do they get the medication, but it's affordable for them. So it all comes back to transparency and accountability. Right now, what you have is you've got the Wild West of the PBMs that go and negotiate contracts, and they how many independent pharmacies do you see today? You don't see too many of them. Why? Because the PBMs have driven the reimbursement down to maybe $1 a prescription. You can't even keep the lights on and pay a pharmacist to work in a pharmacy at $1 a prescription. And they take all these savings and they go to the insurance company and say, this is what we can save you, including all the rebates that they are procuring from all these insurance companies, some of which go to the insurance company and hopefully down to the patient. But a lot of them, they keep those rebates for themselves, but nobody knows because it's not transparent. I personally believe it's a conflict of interest. They should be doing what they are fundamentally enshrined to do, and that is be a middleman between the insurance companies and the pharmacies to establish who's eligible, what drugs are eligible, what drugs are not. But they should not be profiting from the dispensing by taking billions of dollars from drug companies and rebates and helping create their bottom lines. If you look at the capital worth of these 3 PBMs, it's in the billions of dollars. They didn't get that because they're getting switching fees of 30 cents like they used to get when I used to process a prescription and they used to pay me online. They're getting their money from all these other sources and DURs and audits and things like that.
You know, especially if they're connected, if I can use that term, connected with an insurance company, a lot of times the PBM itself may not be making the big buck, but they're funneling it back to the insurance company. It's not the rebates on the back is not coming to the patient.
Right.
So, you know, who's profiting where?
Well, exactly. I mean, the savings rarely go to the patient.
Yeah.
Let's be very frank about that. And you can attest to it. Just go to the pharmacy and fill your prescription and see what happens with that. It's interesting because many times there are stories where a patient will be traveling somewhere, forgot their medication, I say, I'll pay cash for it, and it comes out cheaper than the copay.
Yeah.
But then you can't do that when you come back. So I think that, you know, it's ironic. Our employer pays the insurance company. They make money with that. They're making monies with the pharmacy benefits managers. And who is not making any benefits from it?
Consumers.
The consumer, the patient. And they, you know, as the way things are going, and as we have seen just from a historical trend in the last 10 years, benefits are being cut and cut and cut. I mean, right now there's a big debate also with the Medicare Advantage versus not Medicare Advantage. And that has to be evaluated. Things have to be, in my opinion, maybe this is my educator academic hat, but you have to study these things. And if you have the data, you present it forward. And policy then has to follow that. That'll make that happen. We live in a capitalist system, which means we're here to make money. But sometimes we go a little too far, you know, and we say, yeah, that you're making an awful lot of money, but somebody's suffering over there and they're paying you. So those are the type of regulations we need. We're not talking widgets here. We're talking medications for human beings, for Americans, for individuals that are trying to make their lives successful, to make their you know, offer opportunities to their children. So let's not nickel and dime or $10 and $20.
A lot of it is not, and this is, it comes as far as when you're looking at regulations and things like that, and sometimes, well, just like what you were talking about with, oh, I want to make sure he gets one for the school and one for home. It's the ridiculousness, and I'll use the term ridiculousness of some of the decisions that are made. And sometimes, I see it a lot of time with government, we have a problem, but nobody really looks at the problem and says, where's the root of the problem? There's a lot of, sure, we've got a whole, 66 PBMs. Okay. Well, we have to find some commonality that everybody can live with as far as, okay, let's regulate this. This needs to be so that everybody has access to these drugs. But we don't need to regulate that. That's a little bit too much. And to come to a negotiating, like, for example, when you're talking about pharmaceutical drugs, for every, you kind of mentioned, for every drug that actually makes it to market, there's hundreds that don't. And you have to look at those hundreds. How far did they get? Okay. Phase 1, phase 2, and phase 3 clinical trials are going to cost you probably close to $300 million, depending. And the depending can go up and down.
Mm-hmm.
And if it doesn't make it, if it's not passed by the FDA, that money is out the window. And that's why companies go through a lot of lengths to try and salvage what they've got.
But also remember, pharma spends more money in advertising than they do in research today.
Yeah.
And we are the only country in the Western world, I think actually the entire world, that allows advertisements for medications.
Yeah.
Of course, they have to spend 50% of the commercial time listing the side effects,
Right.
or death. And you're going like, wow, okay.
That's a biggie.
Yeah.
Unfortunately, that's with a lot of, that's where they always go back and you should, consult your doctor, and this is the information that doctors need to have. Okay, something new comes on the market, they need to have the details, and they also, there should be allowances for that doctor to take the time to get to that information too. Now, oh, by the way, here's a 5,000-page booklet, read it, and then you can give them to your patients. So the doctor's up to speed with what? Because there's, I say there's sometimes when you're talking about mental stuff for mental, because mental disease is a lot of rare, but percentage wise, it's a smaller percentage. But there's other types of diseases that are also rare. You start looking up something and say, oh, by the way, there's only 4,000 people in the entire world that have this disease. Can you imagine what the cost of the drug is for that? Astronomical. So how are those people going to get taken care of? And that has to be looked at because, okay, sure, common cold, you got tons and tons of people making stuff for the common cold. Nothing works, but
Well, they say if you take medication, it'll last a week. If not, it'll last about 7 days.
Right, yeah. Oh, you read the label.
Dr. Greer, you had a comparison to the advertising that's allowed in other countries.
Right.
Overall, in terms of access to medications and costs, how are we doing compared to other countries around?
Oh, we're not doing well.
Is there another country that's a model?
We spend twice as much money as the second most expensive country, which I think is Switzerland. But our outcomes, we rank in the low 30s to the 40th in health outcomes in the world.
Why?
Because we don't do anything to prevent. And for example, the difficulty I have with the advertising is a patient comes in and says, okay, this is what I want.
Right.
Well, but it doesn't fit in your profile. Yeah, but they said it was the greatest drug in the world. So it's important to have an educated consumer, but an educated consumer that's not being educated by advertising. That's like when a pharmaceutical rep used to come into our office. My thing would always give me a peer-reviewed journal. Don't give me your literature because I know it's all going to be good stuff.
Right.
So give me the actual articles that these are based on and I'll read them. Because why? If I'm prescribing a medication that can have extremely adverse effects to a patient, I am responsible for that. And the other problem that we have is say, consult your doctor. Well, we have a shortage of doctors. It's like my father, God rest his soul, when he was diagnosed with prostate cancer, His urologist was an old friend of mine. So I called him up and I said, listen, in a case like this, I don't want you to treat me as one of your professional peers. I want you to treat me as a family of your patient. And his response to me was, all right, give me a call. I'll call you back a week later. So the doctors are extremely busy, pressed for time. There's a lot of things going on. Now, some regulations are good. Like, for example, in what I like about Medicare Advantage is you have to fulfill certain things. You have to have screening tests that are done. That's how you get, which is a good thing because that's evidence-based. This is what tells us that a person can live longer. But what you're doing is you're taking away the professional relationship between a physician and a patient, the interprofessional between the pharmacist and the doctor. Because I remember back in the day when my hair was black, as I was painting the house, that's what happened. That when we made rounds in the hospitals, there was always a pharmacist with us. And that's how you made rounds. Because, back then we didn't have these computers. I remember the first ones to come out with computers and which worked really well was the VA hospital, especially with pharmaceuticals. So this way, a vet that's being treated in Seattle, if he's traveling and ends up going to a VA in Chicago, guess what? They have all his records.
When I was in pharmacy school, I went to USC School of Pharmacy, and we did rounds at the county hospital. We did rounds at the VA Wadsworth with the physician, interns, and we were collaborating together and making good decisions on the best interest of the patient. We didn't have to worry about formularies at that time, but it's a collaboration. Today, you don't see the detailed people coming into your office and giving you the perspective with the unbiased journal articles and leaving you with some samples so you just don't jump into a drug, that you can sample it out to a few people and see if what they claim the drug is doing that it's actually doing. But also getting back to something that you mentioned earlier about legislation. The PBMs are multi-billion-dollar companies, and they hire the top lobbyists, and you wonder why we're sitting here today in 2022 trying to figure out how this black box extracts billions of dollars from a consumer that gets their medications, and why we haven't been able to solve this problem. And I'll tell you that when Ronald Reagan, when he first got elected president of the United States, a reporter asked him, well, Mr. President, because remember he was in the Screen Actors Guild in the private sector as an actor, he said, how do you define politics? He says, I define it as the second oldest profession, although it bears a very close resemblance to the first. And this is why you have not seen any real comprehensive PBM legislation coming out of Washington, D.C. that ensures transparency, that ensures that any rebates that are garnered by a PBM are passed directly through to the consumer to lower their prescription costs.
Is it something that can be handled at the state level? Is there a role for our state legislature?
Well, I think there's 21 states with 32 or 33 legislations already passed in this country, and more coming on now.
I think, though, eventually it's going to need to be some sort of federal, when we're talking about, to make sure that all patients have access to all the different types of drugs. There's going to have to be some sort of commonality with certain areas and that's going to take federal legislation. One of the things I want to go back to, you briefly mentioned, talked about Advantage, and by the way, I happen to have it. One of the things I love about it is that it's got me off my butt, and
and say that
into the gym.
Incentivizes you.
It covers a basic membership to for workout, whatever. And that kindly got me off the dime.
They're investing in your good health, so they don't have to pay for any medical bills.
And you have good MA programs here in Las Vegas. I come from South Florida, and South Florida had twice the rates of Medicare fraud as the rest of the country combined. So I could see where this extreme goes over there. The other extreme is I've seen systems out here that are really good, and you push for it. Do you know when the first time in this country it was suggested we had prepaid health systems? After the Great Depression, because Americans couldn't afford it. Never passed in Washington, but it was, because you're in a system now. So a system talks to themselves. They coordinate. If the doctor's busy, guess what? Somebody's going to take your call, and they're going to make sure somebody calls you back. You know, when you need to see a specialist, you get referred to a specialist and you get there.
One of the other things that, with the advantage, what you need to focus, or we should be focusing on, health.
100%.
And not healthcare. Health, because you want to look at the whole person and not just, you don't want to just see him when he comes in the door falling apart, him or her, I'm sorry.
Yeah.
And you know, you're about 3 minutes from going to the hospital. And that's where something when you're talking about testing or the idea of, working out, etc. And that's where you need to, this whole, and the problem that we have as far as the money spending is, an old friend of mine mentioned, we were talking about Obamacare back in the day, and he said, you know, they could have solved this very, very simply by elevating the community health centers and start focusing on health, not healthcare, but health.
But the community health centers, the federally funded health clinics, are so overwhelmed.
Mm-hmm.
They are so,
But
I
they
mean,
could have put that money
right.
into
No,
that.
I couldn't agree with you more. I mean, those docs are really, really overworked. So it becomes important. But what you were talking about is what we call the social determinants of health. And it's, in some studies, it's estimated up to 80 to 90% of the causes of all disease in this country. These are non-medical causes. So we know that. We know that right now in this country, your zip code is more important than your genetic code for how you're going to survive or how you're going to suffer and when you die. There are enough in the literature, and having seen it, where one street divides a 15-year difference in mortality. Wow. There's a famous study from New York that actually tells you for every mile you take a subway from Manhattan to Harlem, how many years are decreasing in a person's survival. So by addressing those things, you really improve the health. We emphasize that at the College of Medicine. And actually, we in our prior institution were the first ones to teach this in North America, including Canada. But it becomes vitally important because if you don't have that, we're even working on technologies now when we go into somebody's household to treat them, that through digital visual things, we can see what you eat. We can see, you know.
DNA and there are some, I mean, depending on where a person's ancestors, you know, came from areas, there's factors of that, factors of, you know, I guess, quality of life, factors of, you know, how long, you know, you're talking about the subway. Well, is that a fact because you're smelling all the fumes from all the stuff in the subway? And
well, it's actually the life expectancy of the people that live in the area. Oh. As you travel down, you go poorer, the life expectancy goes down. I in South Florida lived in a city called Coral Gables, which I'll refer to as a city for the financially gifted. And then Calle Ocho or 8th Street divided the city of Miami from Coral Gables. There was a 12-year difference in survival, which side of the street you lived on. Mm-hmm. You know, in Coral Gables, you had a financially better off, better educated, things of that nature. I mean, there was a recent paper by Ann Case from Princeton. She's an economist who does the morbidity and mortality studies. This came out in 2017. It was called Deaths of Despair. And it was mostly our generation, boomers. And what it looked at for the first time since 1917, morbidity and mortality in the United States was going up. No other industrialized nation had that. And what it turned out to be were non-Hispanic whites, mostly rural. But the differentiating social determinant was those of us that, and these deaths of despair were suicide, opioid overdose, and alcoholic liver disease. They didn't go beyond high school. Many didn't even go to trade schools. So their income was going way, way down. And there you have the mental illness, the depression. All three of those diseases are related to a mental illness. And so, you know, we have to start addressing these different things, and you can do it. We do it here. We actually follow the social determinants on a longitudinal basis. And then what we do is you got to develop new ways of of intervening. It's really easy for us to go to a doctor. Whatever job we have benefits. We get paid for that day going there. But if you're an hourly worker and you don't have benefits, one visit to the doctor means you make 20% less that week, plus what you got to pay the doctor, plus what you got to pay the prescription that he writes or she writes. And, you know, it becomes important that we take care of people. One of the things we've seen, unless you mitigate the social determinants, you're not going to get to the mental health issue. And if you don't get to the mental health issue, you're not going to get to the physical health issue. To the point where when we were addressing this with the state of Florida and then respective hospitals, we were giving the state and the hospitals anywhere from a 900 to a 1,600% return on a monthly basis on their patients, because they weren't utilizing the ED, they weren't utilizing this resource or that resource. We were keeping them healthy. Healthy actually brings the cost down.
Mm-hmm. Mm-hmm.
Let me gauge each of your levels of optimism. 5 to 10 years from now, what does it look like? Are we a lot better off? Are we somewhat better off? Or are we worse?
Go ahead.
Well, I'm hoping optimistically it's going to get better. I mean, they just passed the Inflation Reduction Act. We didn't see any PBM modifications in there. That's why I'm saying it's going to be a challenge. But I don't think we have a choice as a country. I mean, there's only so much we can afford, especially being $31 trillion in debt. We got Medicare that's supposed to be out of money by 2034. We have to make some very definitive decisions, and medicines are a big part of the cost of healthcare. So we really don't have a choice. We have to address it. And we got to cut the fat, and we got to cut out the middleman and get PBMs in the business of doing what they do well, and that's adjudicating claims and showing formularies and making sure that they're doing everything they can to take care of their insurance clients. It should making sure that their copays of their patients are affordable so they can get the medications that they need and deserve. So I'm optimistic that it's not going to be an easy job, but as a future legislator and as one that served 27 years in elective office, it's a fight I'm willing to continue to take on.
Yeah, we definitely. I'm optimistic. I think that what is the thing, in talking about health, and unfortunately, I waited until I was 70 before I started thinking about, I better be healthy. I think that we need to start getting the message out to people and being proactive with rewarding people for being healthy, and not waiting until they're 70, and not doing all the things that I did when I was 25. Which I paid for. I think we've got to make some changes. We've got to make some changes in lifestyle, but we've got to make some changes in the way we look at things. We don't wait until it's broke.
Right.
We got to do something about it.
Jim, I agree with you and with you, because I'm optimistic. I don't think there's any problem that when Americans put their collective minds together, we cannot solve anywhere in the world. And I truly believe that. And that is the beauty of the diversity of this country, the diversity of what nations we came from, ethnicity, race, etc., culture, it doesn't matter. But bringing these to the table, we got to get past this bickering between blue and red. We got to get back to what is the best for America. And instead of accusing and attacking, because I had worked up in the Bush senior administration and then the Clinton administration with HHS doing advising there. And before all this social media, both sides of the aisle actually worked together beautifully.
Yes.
Because it wasn't a matter of, let me get out of this committee meeting so I can make a public statement. It was what democracy is really about. Democracy is slow. Dictatorships are quick, but this is the country we chose. And I think it's like they said, if we're not the best system in the world, we're way ahead of whatever second. And we just it's the pendulum swings, but we have to be mature enough to say, you're here for your clients, you too, I'm here for my patients. That's the oath I took. So it's important we get back to that.
And what's all of this? I hate to say it, where the young people have their head locked onto their phone. It's almost like an attachment. What's that doing? And we start talking about mental problems, and I don't think we scraped the surface as far as what's causing some of this stuff. And what's the ripple effect going to be with the whole phone situation?
Well, it's not just the phone, it's the connectivity.
Mm-hmm.
So
Yeah.
if you're on your phone all day reading 17 million articles, how do you process that? How do I remember, I remember driving home before beepers and cell phones. That actually gave me a half hour just to, reflect on my day.
Right.
What did I do wrong? What did I do right?
In the few minutes we have left, there's so much information, as we said at the beginning, and it's so convoluted. If you could give just one piece of advice to the uninitiated person, the layman who wants to become better informed, what is a resource, what is an action they could take to improve their level of education? Jim?
Yeah, I could say you could start by reading the IRS code, and that'll be a relief when you start reading about PBMs.
And put the phone down.
Yeah. Trying to be informed. It's hard to really be informed. You have so much noise, and I call it noise out there. There are various organizations, and I got to admit, there's ones that I pay attention to in DC. And unfortunately, sometimes they are the problems. They are the K Street people. But also there are trade associations that really work for the people, and they've got a better understanding of what the problems are. Just as an example, I happen to be with Nevada Biotechnology and Health Science Consortium. We happen to be an affiliate, a state affiliate to bio.org, which is biotechnology innovation organization in Washington, D.C. And we go back there, and we also get information from them. And a lot of the stuff that I reference to in as far as PBMs, I learned from a lot of their publications and stuff like that, what's going on, whether it's biotechnology, or they're also involved in bioagriculture, biodiesel, but also things that are happening that have a associated effect with the industry. Some of those that are really good but it's hard for the layman to really sort out what's out there. But just, I'd say, ask questions. Find people that they ask questions. At some point, you're going to find somebody that knows something.
Jeff, what's something somebody can do?
Looking for patient advisory organizations like the Consumers for Quality Care. The president of the AMA just wrote an article specifically about PBMs and why we have problems with delivering lower cost pharmaceuticals to people. So reaching out to these advocacy organizations and seeing what they have to say.
Dr. Greer, any advice for the
I would say have a really good relationship with your physician, your pharmacist.
Yeah.
That's the first line there, number one. Number two, we physicians should be prepared to advise our patients as to where to go online to get the appropriate information. That way they could do research themselves. I'm optimistic, like I said earlier. Medicine is evolving faster now than it ever has in the history of this country, in both delivery, Medicare Advantage, in both pharmaceuticals, personalized medicine, different techniques and things of that nature that we're using now as diagnostic or screening tools. So medicine is changing very, very quickly. And this is America, and everybody is entitled to make a living and make a good living. But there's a way of doing that is the right way. And, as a physician, we take an oath to be for our patients. So it's important that we don't forget that. And I'm glad you're doing exercise now. I, as a lover of great literature, will always listen to George Bernard Shaw, because he says whenever I get the urge to exercise, I just lay down till it goes away. So
Well, this has been a tremendous and very productive conversation. Thank you, Dr. Joe Greer, Jeff Stone, Jim Lamb, and the Latin Chamber of Commerce. Thank you so much for your insight and sharing your knowledge and experience with us.
Thank you.
Pleasure.
Thank you. This was fun.
Yeah.